Hello and welcome everyone to the fourth session of Quick Revision Series Pediatrics, and today's topic is cystic fibrosis. This is very important topic for clinical aspect as well as DNB and MD pediatric theory exams and CPS or DCH exams. Also many MCQs can be asked in various competitive exams where pediatrics is the subject which is asked. Okay, so what is cystic fibrosis? This is inherent multi-system disorder. Just keep in mind, not only the lungs are involved, but it is a multi-system disorder. There is dysfunction of the CFTR protein, the cystic fibrosis transmembrane conductance regulator protein. Sometimes the full form of CFTR is asked as MCQ, and even we commit mistake in solving that question. So CFTR protein is cystic fibrosis transmembrane conductance regulator protein. Okay, most cases of exocrine pancreatic insufficiency in early life, and cystic fibrosis is the major cause of severe chronic lung disease in children. Okay, so what are the complications of cystic fibrosis? Mainly respiratory complications. All those you can go through these: bronchitis, pneumonia, bronchiolitis, atelectasis, nasal polyps, sinusitis, mucus infections commonly seen, ABPA predisposes to ABPA, basically core pulmonale and respiratory failure. So basically there is infection of mucociliary clearance is disturbed, and the infection of mucus may precipitate other disease like reactive airway disease or ABPA, and the later stage, if not managed properly, then may lead to core pulmonale or respiratory failure. Next are the GIT complications. In neonatal age group, meconium ileus can be seen, meconius plug or meconium peritonitis. Distal intestinal obstruction after neonatal period, rectal prolapse can be seen in children with cystic fibrosis. High risk of intussusception of volvulus, pancreatitis, and biliary cirrhosis has also been noticed in patients of cystic fibrosis. Neonatal obstructive jaundice, hepatic steatosis, GERD, cholelithiasis, growth failure. Why growth failure? Due to malabsorption, because the pancreatic insufficiency, the exocrine pancreatic insufficiency leads to impaired absorption from intestine, and which leads to growth failure. Deficiency of fat soluble vitamin, again due to the malabsorptive function of intestine. So vitamin A, D, E, K are deficient usually in these patients. Even the endocrine part can be disturbed, so insulin deficiency, symptomatic hyperglycemia, diabetes, and some may present with malignancy at later stages. Miscellaneous side effects are infertility is seen, delayed puberty, edema due to hypoproteinemia, again due to intestinal malfunction, dehydration, hypertrophic osteoarthropathy, clubbing, amyloidosis, diabetes mellitus, pulmonal keratoderma, skin wrinkling, which can be a good clinical sign sometimes in a patient you are suspecting as cystic fibrosis. Now, the genetics of cystic fibrosis, it is autosomal recessive inheritance. These questions of inheritance are very much important in MCQ exams and OSCE exams of DNB pediatric practicals. Now, CF gene codes, cystic fibrosis gene codes for CFTR protein, and this protein is made up of 1480 amino acids, and CFTR is expressed largely in where this protein is expressed mostly in our body, in the epithelial cells of airways, in the GI tract, including the pancreas and biliary system, the sweat glands, and the genitourinary system. So if someone asks which are the main organ systems involved in cystic fibrosis, so these are mainly four: the airways, that is the respiratory system, gastrointestinal system, sweat glands, and genitourinary system. So mostly the complications are encircled around these four organ systems which are mainly involved in cystic fibrosis. And why these organ systems are involved? Because the CFTR gene is mainly expressed in these four areas. Next is CFTR mutation associated with clinical manifestation are grouped into 6 main classes based upon how they impact upon the protein structure and function. As such, there are many classes, but 6 are the important classification, classified into 6 classes, the mutations of CFTR gene. So just remember these: mutation of class 1 to 3, these are tagged as severe mutations, and they lead to a complete or nearly complete absence of CFTR function, while mutation class 4 to 6 are associated with some residual functional protein. So just to understand, in mutation of the class 1, 2 and 3, these mutations are considered as very severe. Why severe? Because there is complete or near complete deficiency of CFTR function, while class 4 to 6 are considered as a little bit mild because there is some residual function protein is left. The CFTR protein is somewhat functional. The most prevalent mutation of CFTR is deletion of a single phenylalanine residue at amino acid 508. So F508 deletion, single phenylalanine residue deletion at amino acid 508, this is the most prevalent mutation of CFTR gene. These can be asked in OSCE exam or MCQ exams or even in Viva. Now, the loss of CFTR function impacts critical airway epithelial functions. What does the loss of function of this protein does in body? In the airways, the epithelial function is disturbed. It increases the risk for dehydration of airway surface liquid with loss of chloride efflux and associated increased sodium channel activity. So, the loss of secreted bicarbonate and the acidic pH of the airway surface liquid increases mucus viscoelasticity, which results in failure of mucociliary transport. So this is the mechanism how CFTR function, decrease of CFTR function due to mutation leads to symptoms and signs in cystic fibrosis. So first point, it's given increase the risk of dehydration of ASL, that is airway surface liquid, with loss of chloride efflux, which leads to loss of bicarbonate and the acidic pH of ASL. The bicarbonate are lost, so the pH will become acidic, and these acidic pH of ASL will increase mucoviscoelasticity, and which results in failure of mucociliary transport. So acidic pH in the ASL impairs normal innate immune clearance of bacteria. So mucus impaction and then overgrowth of bacteria may occur in that place. Loss of thiocyanate also impairs lactoperoxidase bacterial killing activity, and loss of glutathione secretion depletes the antioxidant capacity of the airway, resulting in increased inflammation, increased mucus secretion, and increased mucus viscoelasticity. So these all factors leads to a vicious cycle of infection and inflammation, which is progressive in nature. Now, what are the clinical manifestations of cystic fibrosis? Bronchial obliteration can be seen, bronchiectasis in patients, and in case of end stage or severe disease, opacified paranasal sinuses can be seen. So a patient come with recurrent respiratory tract infection, and if you go order CT scan, then the opacified paranasal sinuses and recurrent respiratory infections with coarse repetitions may suggest a diagnosis of cystic fibrosis. So these are good clinical findings. Large nasal polyps may be seen, pancreatic dysfunction, intestinal gland distended with mucus secretions, focal biliary cirrhosis, endocervicitis, epididymis of vas deferens, seminal vesicle obliterated or atretic in male patients. Now, clinical features system-wise, gastrointestinal tract, usually the first presentation, it is because in newborn period also it can present as Meconium ileus. 10% of newborn with Meconium ileus may be having cystic fibrosis as the underlying disease. Most with malabsorption from pancreatic exocrine insufficiency. These symptoms are due to pancreatic exocrine insufficiency, which leads to frequent bulky greasy stools and failure to thrive. So other clinical finding, patient comes to you with failure to thrive, not gaining weight and height, and the stool as complaint as per his or her parents, the stool is frequent, frequency is increased, bulky in nature, and greasy stools. So you have to suspect cystic fibrosis in such cases. Fat soluble vitamin deficiency, that is A, D, E, and K deficiency. Hepatobiliary icterus, ascites, hepatomegaly or cholelithiasis may be seen. Pancreas, increased incidence of diabetes mellitus and acute pancreatitis in such patients. And these patients may also present in rectal polyps, mostly in infantile age. It's steatorrhea, malnutrition, and coughing. So, and now next, the respiratory tract mainly involved rate of progression of lung disease is the chief determinant of mortality and morbidity. Like among various patients with cystic fibrosis, if the rate of progression of lung disease is faster, then the condition is more morbid and it may lead to early mortality. A distinguishing feature of lung disease in patient with cystic fibrosis is high prevalence of airway infection with Staph aureus, Pseudomonas aeruginosa, and Burkholderia cepacia complex. So this is a good question that even other immunodeficient patients may also present with recurrent respiratory tract infections, or as some allergic patients, or other factors are also there for frequent SP infections. But how you differentiate that this patient is more likely to have cystic fibrosis? So there is the prevalence of airway infection with Staph aureus, Pseudomonas aeruginosa, and Burkholderia cepacia complex. So if you get bronchial lavage or secretions culture of those materials and you get these three organisms, then this you should raise your suspiciousness for cystic fibrosis in such patients. So these are the three main organisms involved. Now, cough, purulent mucus, early in first year, extensive bronchiolitis, and then pulmonary function abnormalities may occur. Dyspnea, finally core pulmonale and respiratory failure and deaths. And there is high risk of pneumothorax in such patients. An examination, you will see increased AP diameter, hyperresonance, rales, expiratory wheezing, clubbing, and cyanosis at later stages. The paranasal sinuses are opacified. JUT, genital urinary tract, delayed sexual development, males presents with azoospermia, increased incidence of hernia, hydrocele and undescended testes, and females secondary amenorrhea, cervicitis and decreased fertility may be seen. Sweat glands, excessive loss of salt may lead to salt depletion, and serum of these patients shows hypochloremic alkalosis, and the taste of skin of these patients, if you kiss a baby with cystic fibrosis, he or she may taste salty. So there is excessive loss of salt and salt depletion via sweat glands. So the serum of this patient is hypochloremic alkalosis is seen. Now, diagnostic criteria of cystic fibrosis. This question may be asked as a short note 5 marks question in DNB theory exams for any MD or DCH exam. It was the diagnostic criteria for cystic fibrosis. So, presence of typical clinical features like respiratory, GIT and GUT, or this is not and, this is or a history of cystic fibrosis in a sibling, or positive newborn screening test for cystic fibrosis. If any one of them is seen, plus, now this is plus, so any one of those three and plus laboratory evidence of CFTR dysfunction. How CFTR dysfunction is evident in lab test? 2 elevated sweat chloride concentration obtained on separate days. Now, or identification of 2 cystic fibrosis mutations, CFTR mutations, or an abnormal nasal potential difference measurement. So first three, any one of those first three and any one of these three lab findings or genetic testing or nasal potential difference measurement, if these are seen, then it's diagnostic of cystic fibrosis. Now, what is sweat test? The sweat test using pilocarpine ionophorus to collect sweat and performing chemical analysis of its chloride content is the standard approach to diagnosis of cystic fibrosis. It can be asked which of the following chemical is used, then pilocarpine is used. Now, more than 60 millimole per liter of chloride in sweat is diagnostic of cystic fibrosis when one or more other criteria are present. So the earlier criteria we have seen in the previous slides, those criteria and the sweat chloride of more than 60 millimole, then this is diagnostic of cystic fibrosis. An individual with positive newborn screening but a sweat chloride level of less than 30 millimole per liter indicates that cystic fibrosis is unlikely. Even if the newborn is tested positive in newborn screening for CF, then also if the sweat chloride level is less than 30, then cystic fibrosis is very unlikely. Now, what about borderline or intermediate values of 30 to 59? More than 60 is positive, less than 30 is negative. Now, what happens if the value is between 30 to 59? Then reported in patients of all ages who have cystic fibrosis with atypical involvement and require further testing. So this is known as intermittent or borderline value. So these value can be asked in MCQ exams. Now, summary of investigations for cystic fibrosis. This can be important for pediatric theory examination, UG or PG. Now, sweat test is the best diagnostic test considered. Difficult in the first weeks of life. It confirms positive result. Diagnosis more than 60 milliquent per liter is positive. If sweat test is equivocal, then increased potential difference across nasal epithelium has to be done. So equivocal means that between 30 to 60 is equivocal. Now, next is pancreatic function, 72-hour fecal fat collection and stool for trypsin, pancreozymin, secretin stimulation, serum immunoreactive trypsinogen. It is increased in neonates, so pancreatic function can be tested. X-ray has to be done if hyperinflation of chest, nodal densities, patchy atelectasis, confluent infiltrates, high nodes are seen. With progression of the disease, flattening of diaphragm, sternal bowing, narrow cardiac shadows, cyst, extensive bronchiectasis can be observed in X-ray of cystic fibrosis patient. Now, PFT by 5 years, obstructive pulmonary disease is seen, and after that, restrictive, that is fibrotic lung disease is seen in the patients. So this is a good question for Viva and MCQ as well, that what is the pulmonary function test in patient of cystic fibrosis. So till 5 years of age, patient develops obstructive pulmonary disease, and after that, restrictive, that is fibrotic lung disease can be seen. Microbiological finding in sputum, Staph aureus initially, followed by Pseudomonas aeruginosa is virtually diagnostic, Burkholderia ceputia, but it's usually a late finding. How genetic testing is done, what all tests are done, and antenatal diagnosis by mutational analysis in family is previously identified by birth of a child with cystic fibrosis. If in a family a child is already there with cystic fibrosis, so antenatal diagnosis is to be done, and test spouse of carrier with standard panel of probes because autosomal recessive. So if the spouses also should be tested for that. Now, newborn screening important. determination of immunoreactive trypsinogen and blood spots, and then confirmation with sweat or DNA testing. Does not improve pulmonary and long-term outcome. So blood spot test done for newborn screening of cystic fibrosis, and if it comes positive, then sweat chloride test is to be done or DNA testing is to be done. But diagnosing cystic fibrosis in the newborn period does not improve the pulmonary and any long-term outcome of those patients. Now, what is the treatment of cystic fibrosis? Clear airway secretions and control infections is the primary aim. Aerosol treatment with albuterol or saline is used. Daily dose of human recombinant DNase. This is mucolytic agent. Human recombinant DNase 2.5 mg. Enzymatically dissolved extracellular DNA released by neutrophils. So these contains many questions. What is human recombinant DNase, or which mucolytic agent is used in cystic fibrosis? So the answer is human recombinant DNase. What is the dose of human recombinant DNase? 2.5 mg. What role does it play? Enzymatically dissolve the extracellular DNA released by the neutrophils. Now, chest physiotherapy with postural drainage 1 to 4 times a day. 7% hypertonic saline. 7%, not 0.9%, not 3%. 7% hypertonic saline is nebulized 2 to 4 times daily with increased mucus clearance and reduced pulmonary exacerbations. So these are the regular treatment modalities used in cystic fibrotic patients. Antibiotics for acute infection change or most frequent is Pseudomonas aeruginosa, and choice based on culture and sensitivity. Aerosolized antibiotic is tobramycin. So which aerosolized antibiotic is used in cystic fibrosis? It's tobramycin. So this is a good MCQ question. For hospitalized patients, 2-drug regime to cover Pseudomonas, that is piperacillin plus tobramycin or ceftazidime. So piperacillin is used plus tobramycin or ceftazidime is used for hospitalized patient to cover the Pseudomonas infection. Nutritional support important. Pancreatic enzymes replacement is to be given with every meals or snacks. Recommended dose should stay below 2500 lipase units per kg per meal. And vitamin supplementation of the fat soluble vitamins, that is A, D, E and K, is to be given. Ivacaftor, cystic fibrosis transmembrane conductance regulator modulator therapies. So Ivacaftor is the name, very important name, a small molecule potentiator of CFTR mutation G551D present in 5% of the patients. Ivacaftor activates the CFTR G551D mutant protein, the class 3 CFTR mutation that result in protein localized to the plasma membrane but loss of chloride channel function. So Ivacaftor is the CFTR modulator drug, and it's approved for patient older than 2 years of age. These all are MCQ questions, just keep in mind with class 3 and class 4 mutations. The combination of Ivacaftor with lumacaftor is available for patients older than 6 years of age who are homozygous for the 508F deletion mutations. Okay, so tezacaftor and ivacaftor is another combination indicated for patient more than 12 years with 1 or 2 F508 deletions. So different combinations, different age groups. So this was all about cystic fibrosis in short. I think this is more than enough for a short note of cystic fibrosis in your MBBS pediatric exam or DNB or MD pediatric exam, and many important points are also covered for MCQ questions. Thank you very much for your patient hearing, and for more such videos on pediatrics you can subscribe our channel with the YouTube handle of Shishu Care. Thank you.